Yeah, these are like videographer.
You should have your own one, shouldn't you?
I've got one in the clinic and I'm shit at it. So we're going to do a roll with this. Right guys, everyone kind of gather around. Everyone gather around. Right, so we're going to change techniques now. So I think you guys have done a lot better this morning than where we kind of finished up yesterday. I think all the little, all the things we were struggling on yesterday we've managed to pick up this morning. It's always nice sleeping on it because there's a lot of information gets thrown at you at one kind of hit. You always look better in the morning through that. So what we're going to look at now is our rolling technique for the thoracic spine. So this is a technique which I rarely use, to be fair, because I can normally get my body in a position where I have enough kind of weight in the technique in order to use it. However, for smaller practitioners, or if you're seeing a lot of patients that are heavier than you, it's a really good technique for manipulating the patient's body weight against them. So instead of you having to produce all the force through the thrust, it's an easy way to use their body weight in order to create the thrust, yeah? So for smaller practitioners, this is a really nice technique. We do need patient cooperation with this. So if the patient is in like a acute stage, I don't think that this would be a good technique to be using because we're going to need the patient to cooperate. I think this is going to be where we're going to be using the manipulations in order to gain more mobility rather than sort of pain decrease is where we'll probably be aiming for. Yeah, does everyone make sense of that? Good. Okay, so if we sit up, if that's okay. So what we're going to do is pretty much we're going to talk the patient through first, is we're going to put the patient into a position and then we're going to ask the patient to lower themselves down. You can choose to take the patient's body weight and do the whole lowering process yourself. I tend to avoid this because I don't like lifting patients' body weights. I find that, again, it puts me at risk, and I don't want to be doing a technique that puts me at risk, yeah? So with all of the rolling techniques I do, I use a patient cooperation a lot through that. I get them to bend this leg for me. The reason being, with the leg bent, if he then rolls back, so just roll back for me, he has a little bit more kind of coordination through there. If he sits up again, and then has his leg straight, and then just tries to roll back, you see how he has that point where he's like, oh fuck, I'm falling, yeah? So that's what we're trying to avoid, is that kind of falling stage. We're going to be aiming for the mid-thoracic through here, so what we're going to be doing is lining up our whole technique standing, and then when we go down, is we're going to produce the thrust force as soon as we hit the table, yeah? So exactly the same setup as what we've done with our supine thoracic adjustment. We're going to ask the patient to put their hands on top of his shoulders and to hold tight through there. You're going to bend the contralateral knee to the side that you're on, and then what you're going to do is you're going to palpate the area where you are going to adjust. Again, you can use your flat hand contact, you can use your fist contact, or your trigger contact. Personally, as I've done this before, I would always use a flat hand and a rolling technique, yeah? Reason being, you are rolling onto it, which means that is going to hurt, and you do hurt your fingers a little bit. Plus, with a flat hand, it's less of a surface for the patient to roll over. With a fist, it's a bigger surface, you know, it's just a bit more uncomfy, yeah? So palpate to where you want to adjust, and then I'm going to put my MCP contact onto the segment where I'm adjusting. We're going to use all the patient now to sit up straight for us. We're going to use the patient now to flex them into a position. I use the patient's head, so I just ask them to put their chin to their chest, get some flexion in. And my hand is going to be facing up when I put it onto the elbows, not down. The reason being, I'm going to need to get on top of the patient as we go through the technique. So I put my hand facing up like this onto the elbows. I put some pressure in to then carry on that flexion point to where I feel my fulcrum come in. I'm standing at the pelvis, so I'm side on to the patient. I then take my contact to stand facing the head of the table, and then I just ask the patient to take a deep breath in. And on the out breath, if we start to roll back, we roll, and then as we get further down, is we go on top and then thrust. Yeah? Come back up. So we did that nice and slowly. Timing is everything with these techniques, yeah? If we are rolling, and then when we roll down, is we get the patient rolling, nice and comfy, all the way to the bottom here. Then I see you guys go on top, and then thrust. There's no point of putting the roll in, yeah? So come back up. Getting a good ab workout today. So once we've got into this position and we've got our flexion point and the patient is rolling, as soon as they are mobile, we have to be moving, yeah? So we go from this position, I'm in my position ready, he starts to roll back. When he gets to that 45-degree angle, I'm on top, ready to thrust when I get to my point. Yeah? Make sense? Yeah? Come back up, last time. So from start to finish, legs straight, patient sits nice up and straight, because if they're slouching through there, you're going to miss your flexion point. Again, if you have any watches or anything like that, take them off because it's going to hurt. Bend the contralateral knee, arms onto opposite shoulders for us, head down so we get our flexion point come through, select the area, hand facing up so we've got access to get on top of the patient, not down. Hand facing up, we continue the flexion point. We position ourselves so back leg is in line with the pelvis, front leg is in our normal position. Patient takes a deep breath in, and on the out breath we roll back. And then when we get to 45 degrees, we go over, and then we thrust. Yeah? Make sense?
Yep.
Good?
Yep.
Cool. Let's try it. Okay.
Okay.
Exactly the same as what you're crossing.
Okay.
Yeah, kind of went.
You win?
Yeah, it went. As you came over, you wanted to go flat, and then you wanted to move over.
Yeah. Slow motion. Okay, I'm trying. Okay, from the start. Legs straight.
I just thought that. That's why you didn't go on top of it.
Breathe in.
We're going to be doing this to hit primarily the upper rib cage, yeah? But as you can remember from our level 1 course, hopefully, is that this technique can be targeted towards the upper rib cage, can be targeted towards the SC, AC, or the GH, yeah? It's an unspecific adjustment, but we can hit anywhere between upper rib cage, SC, AC, GH, yeah? Remember that one? Remember, if we have a compromised shoulder in terms of stability or any kind of previous history of tear or dislocation on the shoulder, this is not an appropriate technique to be doing. We only want to be doing this on shoulders where we trust the stability aspect through. The reason being, we are going to be using the humerus to actually drive the tools through. So do be aware that if someone has got an injury on the shoulder, we need to make sure that the shoulder is intact before we do this, yeah? Everyone make sense of that? Can everyone remember the technique from level 1? I'm going to give a quick demo on it anyway, just so everyone is aware of it, and then we're just going to line it up sitting up. So, table height's exactly the same. Then what we're going to do is place the patient's hand onto the neck. Patient's elbow goes nice and floppy for us. I then turn to face the patient, elbow to elbow contact, hand onto GH, we roll over, we contact the medial corner of the scap and the spine, we find the rib angle in between, point to the rib angle, roll in, and our contact is going to be like this, and that's where we thrust from. So we're in this position, we find through here, we then roll the patient on, test, patient's arm goes up, hand, we hook in, and then our driving force is like this, so then our thrust will be deep breath in, and then out, and we drive, and that's our thrust, just down into our oblique angle. If we now sit the patient up, we're going to do, exactly the same technique, but now sitting. So we use the patient's contralateral leg, so that he's got something to lower himself from. We are then going to do the whole setup in this position, so that then we can then go down and thrust. Unlike the thoracics, where our thrust was AP, our thrust has to be oblique still on this one, yeah? So our thrust force, once we get the patient down to the bottom, still has to be with that front knee dropping, yeah? And we're going to be taking the patient obliquely. So what I do is we get the patient in this position, yeah? We're then going to find where we want to thrust, so we find the medial border of the scapula, we find our spine, and we find just in the middle where our rib angles are. We then can take our contact again, which is like this, hand into the middle, and that's where we're thrusting from. We can go below the scapula, which is my preference, or with the roll-in one, is we can go above the scapula, yeah? I find the above the scapula one a little bit awkward, but some of you guys may find this more beneficial for use, yeah? So try both of them, don't just go with what I've said. So, once we're in this position, I fix to where I want to thrust, so I find my area, I go through here and I contact. Patient then takes a contact onto their axilla with their hand, and I go just on top through here. I then put my axilla onto their elbow contact, and then the patient puts their chin to chest, they flex down, and then we make the focus through here. Patient is then going to take a deep breath in, and then on the out breath we lower. So we start to lower down, and then we thrust. Make sense? Yeah? Can everyone remember the technique for the first? Yeah. So all you're doing is you're lining the technique up instead of here. We're lining it up here, and then we're just taking the position down to thrust. Make sense?
Yes.
Yeah, it should be quite, yeah?
Sorry, can you show us again? I forgot to start my camera. Sorry.
Get someone to airdrop it.
Right, so once we're in this position, yeah, I'm standing next to the patient facing this way, medial border of the spine, hand flat, thumb across, this is where you're manipulating from. I either take contact below the scapula or above the scapula, never this way, yeah, because we're going to be blocking the thrust. Once we're in this position, patient's hand goes into the axilla, I go on top of their hand and I contact into the axilla. My axilla contact onto the olecranon, we flex, head down, we get our contact position, patient takes a deep breath in, and on the last breath we follow into an oblique drive. Yeah? Everyone good with that?
Yes.
Cool, perfect. Which I love this adjustment, I think it's a really nice technique, but there is a lot of technique to it. When I was first originally shown this technique, they just said, just flip it, yeah? And I was baffled on how to do it for ages until I learned it properly. This is people think this is more of a kind of party trick technique, but it's actually a really good technique to use in conjunction with shoulder rehab, wrist rehab, lots of different things. This joint is going to facilitate this pronation and supination through the forearm, sorry. And in terms of rehabbing with the shoulder, is we need that rotation. We can't really move the shoulder without moving the hand. So we don't have this spiral motion coming through. Our shoulder movement is inhibited, yeah? So in terms of, is it a worthwhile technique? Definitely. I use it a hell of a lot, whether it be wrist injuries or shoulder injuries or neck injuries. It's again to see whether or not that pathway, we've got that rotation through it. So you're thinking fascial stuff, or if you're thinking just, like actual joint blockages through there. Really interesting technique to work on. So again, we're not going to be doing this if someone has a hypermobile elbow, yeah? If you're looking at someone's elbow, that is tiring. Yeah. If you're looking at someone's elbow and it does the opposite to this and it moves a lot, yeah, So if anyone, has anyone got hypermobile elbows? Yeah, like that. That probably is not, you could do it, but you know, it's not going to be the nicest or most comfortable to get into that hyperextended position, yeah? So do be careful, especially if people have had a history of, you know, like elbow fractures or ligament injuries on the elbow. Just be aware that it might not be the technique for that patient, yeah? It's not for everyone. Right, so what you can do, firstly, is taking a contact onto the patient's wrist, yeah? So around the wrist like this. We don't go over the radial ulna because you see how the hand's really floppy here, and we don't go just on the wrist because it's a bit loose through there, yeah? So we go over the radial ulnar joint and we take contact through here, yeah? So you see how now I've got nice firm contact through everywhere, yeah? We're going to then locate the radial head. If you can't locate the radial head, just find the olecranon and then just come in and go up and you'll find a bumpy bit. When you find the bumpy bit, start turning it and you'll feel it rolling under your thumb, yeah? Don't be alarmed if you're struggling to find the radial head. Some people do find it quite tricky. Just give me a shout and we can do it because we often get people thrusting up here and stuff, yeah? If we're not on the radial head, we do need to actually push it when we are thrusting it, so the technique won't be going through, yeah? Once we're in this position, there's a lot of body positioning and moving around now, yeah? So you can do this in seated and in lots of different positions, but supine is probably the easiest to do it. We're going to fully supinate, well, I always get supination and pronation confused. Supination, yeah. Pronation. Fully pronate the forearm, yeah? So don't tell anyone, cut that out. I always say back to front. Right, so full pronation of the forearm. So once we've fully pronated, you see how I'm starting to push now with this arm, but what I'm doing is actually using my body to do it. So I'm fully pronating, and then my hips are twisting, and then I'm pushing down through my arm onto the joint. So now all I go is take it to the barrier point. Patient takes a deep breath in and out, and on the out breath I follow, and we thrust. Yeah? And that's our thrust point. Real nice, boom, easy. Make sense? Yeah? Do try and use your body. I don't want to see people doing bang like that into hyperextension. Go over the joint, make sure we're up, over, and that is our thrust, is we're moving our hips to thrust in. Make sense?
Yes.
Yeah? Cool, let's try that.
Back please. Alright. Okay. There we go. You're a big guy, so what we're gonna do, go like that. There we go. Press my hand there. Alright, take a deep breath in for me, please. And up. Go.
Nice. How do you feel?
Good.
Yeah? Any critiques on that? No? So you was kind of between the axilla hold and the stomach hold. So you kind of like up here.
Yeah.
So you want to either, we was trying to get into the axilla contact.
Or go with this.
Yeah, or go with the stomach, yeah.
Yeah.
Because by putting the elbows in towards the rib cage, you run the risk of getting injured quite a lot. Just if anyone has had an elbow in their ribs before, it's fucking painful. So be careful of that. But no, pretty good. Thrust was nice. Use your body. Yeah. Good. Anyone else feel confident to get?
Could do the. Okay. So I'm just gonna do the easy one to start off with, and I'm gonna do the rolling. I want to use my body. I'd like your right hand, please, just over here, and this hand just here. And what I'm gonna do is just gonna get the hand, my elbow to his elbow, just roll him over. I'm gonna get my percival just underneath his scapula, and then roll him back over, and I'm gonna get my axilla just over his elbow and get this hand just here. I'm gonna tuck that in nice and tight, and ask my patient to breathe in and breathe out. Follow. And then the next one, Is that right? If you just sit up for me.
That's nice.
And then same position.
Mm-hmm.
I use my pisiform as well, just underneath the scapula. Same thing again here, but this time I'm just gonna
Try and get your thumb underneath.
my thumb. Yeah.
Yeah.
But this time I'm just gonna fall down, so tuck that in nice and tight, and patient will breathe in and breathe out. He's gonna come follow, and trust.
Yeah.
And
Only thing you could have done is use the legs,
yeah,
just to help him get down a little bit easier.
sure.
Look really nice.
Thank
That's
you.
Good.
Appreciate it.
Anyone else want to give it a go?
So just feel if there's any tightness here. And relax me, breathe out.
Nice. Look good. Everyone's cracking well today, isn't they?
Yeah, it's my elbow as well.
You could have lowered the bed a bit, just a bit more.
Lower.
Yeah,
Yeah.
just a bit more.
A seated survival technique, yeah? This technique is really, really nice. I find this technique really nice to do with patients that are a bit more apprehensive with the cervical adjustments, yeah? You tend to find that people relax into this position a bit more. I don't know why, but they just do. You can do it standing. I tend to actually sit down next to the patient when I do it, but we won't tell you to do that today. But yeah, it's just a really nice technique. It chills everyone out. And yeah, they don't have to be laying down, so if the patient is acute, they don't have to get to the lay down position. So it's just another sort of addition that you can use from it. When we do the technique, we should be in body contact with the patient the whole time to make sure that we are close to the patient. And all we're going to do is we're going to be manipulating the opposite side to what we're standing on, yeah? Only thing that we need to be really careful of in this technique is because we're putting our hand in front of the patient, is making sure that we don't come across the throat at all, yeah? So again, some of us are still, when we're doing C0, C1, or the cervical manipulation, are still getting the hand contact on the neck. We have to be very conscious of this because left hand in this case is going to be our driving hand. So if we are on the neck and we try and drive with it, we can injure the throat, but we can also compress the vasculature through there, yeah? So do be very, very careful about that, yeah? So very, very hypervigilant in terms of patients with the practitioner now. If you are feeling any contact on your neck, please let the practitioner know, and then we have to change the technique around a bit, yeah? Make sense? So what we can do is just palpate down articular pillars, find a level we want to adjust, something nice and inflamed for you. And then I'm going to locate it with my middle finger here, and then I'm going to go around the other side and locate it with my middle finger, yeah? I take a contact onto the posterior facet, my thumb contact is now on the jaw, and I'm nice and secured in with the patient. I'm leaning into the patient with my stomach so he feels nice and secure, and we're moving as one. My other hand then takes an occipital hold. So people on this side, you probably want to go this way, just in case you can see it. Because I can't turn him around in a minute. Is I'm going to take an occipital hold just like this to secure the patient's head. Once we're in this position, I'm going to just side bend the patient's head to my level, and then I'm going to rotate the patient's head away. Yeah. So that's all the movement we're going to put in. Slight side bend and rotation. Once we find that fine point through there, you ask the patient to take a deep breath in and out, and we follow, and we thrust. Yeah? Super nice, super easy, really comfy technique. Hardly any movement put into it at all, yeah? What I don't want to see you guys doing is like that, and then yanking their head around, yeah? It's a real soft technique. Find our location, just put it into side bending, nice and secure, rotate to your level so you wind up the level, and then it's just a small thrust at speed. Yeah? patients, be very vigilant that if anyone is putting pressure on your neck, you tell them immediately, yeah? Everyone cool with that technique? Yeah? Anyone want me to go through it again?
Is that right if you do it from the other side? So the other way around.
Mm-hmm.
Thank you so much.
Right, so again, exactly the same principle. I'm nice and secure with the patient, yeah? We give him a little cuddle, make sure he's okay, yeah? And he's fine. Right, so then palpate through the neck, yeah? Find our level that we want to manipulate. So we're going to target just through here. We can go down low, we can go wherever we want through the cervicals. I point to where I'm going to be manipulating. I'm around the front. I go just posterior to the facet joint. Make sure my thumb contact is nice and on top. Secure the patient's occiput. Then I side bend to my level. I rotate away. And then I get the patient to take a deep breath in and out. And then thrust. Yeah? Everyone happy with that? Yeah? Cool. Let's do it. We're going to be targeting the lower portion of the rib cage. So we're going to be targeting from scapular angle down, really. You can get into kind of T6, T7, that kind of area. But we're going to be focusing predominantly here. I'm going to need to step, by the way. So this is a really nice technique to use. I find if doing manipulations on the bed, I want to be a bit more active with my patients, incorporate breathing techniques, that kind of stuff. I tend to use this a little bit more. It's quite a fluid movement. So the only thing you need to be careful of is the patient, we're going to use rotation in this vector. If the patient is struggling with any lower back pain, obviously we're going to be rotating them like this. So we don't want to actually probably do this with anyone suffering with lower back pain, yeah? So do be aware that the position we're putting them in is slightly provocative, yeah? The reason we're sitting like this on the bed, which is probably not the most comfortable for the patient, is because we want to fix the hips and the pelvis as much as we can and minimise the amount of movement going into the lumbar spine. We could do this in a seated position facing that way, but again, it's going to be a bit more difficult because we're thrusting into rotation. His legs may slide, you know, it becomes a bit messy, the whole technique, yeah? So I predominantly do it in this position. You can try it in other positions, but I've tried it and it kind of goes a bit ski with. So I would definitely try doing it in this position. Patient's going to be right at the back of the bed, so we can get his come back ever so slightly. That's perfect, yeah. And then I'm going to be in contact with the patient the whole time, yeah? He's going to cross his arms onto opposite shoulders. And just relax through them. Good. So you see how my axilla contact through here, I'm firm on the front, and now I've got full mobility of the patient, yeah? My hip is going to be into his back, and you see how my front leg here is in contact with the bed and the patient, and this leg is going to be the one that I'm driving everything with, yeah? We're going to take a contact onto our rib angle using the thenar eminence, yeah? I'm just through here. I'm going to use my elbow to lock in against my chest wall. Sometimes what I do is I almost hook in against my ASIS to give me like a kind of firm point so that when I move, the most important thing is my arm doesn't move. But where we're thrusting into rotation, what we see people do wrong a lot is they try and push the rib cage. So they come through and they do that and they slip off. That's not the technique, yeah? So we're in this position, we're round like that, and then we're thrusting by spinning my body, yeah? So what I'm going to do is I'm going to take my contact onto the rib head. Much like with our skin drag before, I'm going to take my contact just onto the TES here, and I'm going to skin drag onto the rib that I want to adjust. I'm going to then start finding where my barrier is with my rotational vectors. And then you see how I'm doing it just by stepping my leg. And then once I've found it, I'm going to come back off. I'm going to ask the patient to take a deep breath in and out. And then I follow, and thrust. So it's a small movement like that. Make sense? But at any point, I do not push the patient, yeah? And sometimes you get these going like the whole kind of spine. There we got 2 ribs, I think, and there's just small little pops, yeah? So again, you want to be as specific as you can to the location, but with these kind of broader techniques, is you're not going to be as specific as you feel. So don't be alarmed if you get a lot go, or if you don't get a lot go. You know, we're just going to go back and retest the position. Make sense? Yeah? So most important thing, guys, lock in here, lock in there, step around, and then that's your generator of force. We are not pushing the patient at all. Yeah? So before you start, just get comfortable on this position, rotating, and then lock in, bang. Yeah? Good, nice and easy. Wicked? Cool. So let's just be working on our carpals through here, the first and second rows. So with your carpals, you tend to find, I tend to find when you're thrusting these, you may get a click, but the majority of the time there's no cavitation at all. It's more like a speedy articulation that we're kind of getting through here. Again, if anyone's got elbow injury, a shoulder injury, or any nerve injury from the neck, this would not be a good technique to do, because we're going to be tractioning through there and producing a whipping sensation, yeah? So in terms of if someone is nursing a kind of injury into the neck, you're going to traction it, and anything through the elbow and shoulder would definitely be, you know, like just making sure that everyone's safe before we apply the technique. We can just turn it into an articulation instead. We don't need to do that, yeah? So patient's going to be as far onto the couch as they can, yeah? Reason being, we're going to need to use the patient's body weight in a minute. Sorry, and the patient will be leaning away. So all I'm going to do is take a contact around the thumb and around the little finger, and I'm going to come in on top of the joint that I want to manipulate. So what we're not going to be manipulating is the radial ulnar. We're going to go onto the first row of carpals, and what I do is I select whichever bone I want to manipulate. So yeah, his wrists are super tight, so that's nice and fun. Is I'm going to then take a contact here with the paddy part of my thumb on top, and then what I'm going to do is reinforce on top with my other thumb. Underneath, I interlace my fingers, yeah, so that I've got a nice firm contact. And then you see how I'm getting ready for this now. I'm going to lean back, the patient's going to lean back, so we've got some nice tension there. So you see how that starts to gap the joint already. And then all I'm going to do is I'm going to lean back like this. So I'm just leaning back like that. I can already feel this joint gapping quite a lot. And then all I'm going to do is ask the patient to take a deep breath in and out, and I follow, and it's just whipped through like that, yeah? So back, round, here, and then thrust, and the thrust is down, almost like you're kind of throwing it behind your hip. But what we don't want to do is yank the person's arm like this and throw him over there, because, well, I think I'd struggle. But what we don't want to do is yank their arm too much through there. That's why we've got the traction element in there, so that his weight is counterbalancing traction in through there. We both lean back, I lean in, and then, oh, there you go, little cavitation. And then just bang, like that, yeah? So it's really nice and easy. We do need the reinforcement on the thumb. I find if we try and manipulate like this, it's just too generalized. So try it on top of each other like that, in and round. I take a staggered stance, just like that. You can articulate to start with, just to get the bind point in there, and then bang. Yeah, it's a nice, quick, easy technique. Everyone happy with that?
Yes.
Yeah? Cool. Let's go through that, and then we'll have a break after. On top of the bone, reinforcing on top, and we're trying to almost like inferiorize the bone. That's how the old school thinking would be working, but what we're actually doing is just gapping the joint. So select whichever bone you believe you're on, whether or be on whatever you are, and then just inferiorize like that, yeah?
Perfect.
Thank you. Right, guys, so we're going to be manipulating onto our thumb now. So basically there's two different ways that we can do this technique. One is going to produce a long lever thrust, one is going to be a short lever thrust, yeah. So I'm going to show you the long lever, then I'll show you the short lever. Reasons why you would do this technique, one is just quite a cool technique to crack people's thumbs, it feels really nice when you have it done. So that's one, but two, obviously again, if we're looking like elbow, the amount of pronation, supination that we can get out of the forearm does have a big influence on how the thumb joint is working. So there is a lot of relevance as to why you would be doing it as well. So what we're going to do is you're going to take a thumb contact and we're going to go all the way down just to where we feel this saddle joint come through here, yeah? So just so we're going to be on top of the carpals here, and we're going to be just on top of that saddle joint, yeah? You can see with my other three fingers, I'm literally gripping the thumb so that I'm nice and supported through this position. And then what I'm going to do is stand in line with the patient's pelvis, and then I'm going to put my hand on top, so just like this. I'm going to move my body away from the patient like this. Then once I've done that, I'm going to thrust in like a J kind of position. So what I'm going to
is on the top?
Yeah, so the thrust is going to be like that.
Okay.
So all I'm going to do is from this position, patient takes a deep breath in and out. As I start to build up, and then you thrust just down like that.
Creating attraction as well.
Yeah. So again, it's just like a nice, gentle technique. It feels like a lot because you're pulling through the arm, but all you're doing is supporting through this section, on top, through there, and then that's the movement pattern. So you see how we're fixed, and all I'm doing is dropping my hip through this area, and then you're just with your arm straight, it then produces that kind of J action, and you can just feel the thumb joint just coming up. And you're effectively just looping up like that, yeah? Really nice soft technique to do. Normally crack quite loud. His thumb's not playing ball today, so that's fine. Then our short lever technique, what we can do through there is we then take the same contact that we had with the long lever adjustment, then we're going to go just right on top of it. And then all we do is we almost try and push down, and we can just reinforce onto the joint, and then we produce that movement, just like that. So again, his thumbs aren't very clicky today.
I clicked it earlier to be fair.
Yeah, not good demo. So all we're doing is then producing again the short lever J action through here, yeah? So just like that, on top, so you can either go thumb to thumb contact, yeah, and you break through like that, or you go thumb reinforcement and you break short lever with this. Make sense? Yeah? Everyone good with that? So long lever here, long lever is all about body position, so it's just in front, lock, and manipulate through there. Short levers here, lock, push. Yeah? Good, nice easy one after lunch, yeah?
What about use cases for either or though?
Pardon?
Use cases for short lever versus legs as well.
So we was just discussing a minute ago, and we have done pretty much through the whole weekend as well, is HVT on knees, is like, what's that point of view on it, that kind of stuff, yeah. So I thought it would be quite an interesting conversation just to have with you guys. Feel free to chip in and ask me a question if you have a question about it. But my point of view on the knee, and this is only my point of view, it's not not kind of, you know, what I'm teaching you or anything like that. This is my opinion on knee joints. It's inherently a structural object. You know, we've got lots of ligaments around it, we've got patellas, we've got tendons, we've got meniscus. Everything around that joint is built to make this as strong and as stable as possible. So for me, the thought of putting, you know, big thrusts into it and trying to generate a lot of movement in this area is, you know, for me, I feel like it's a bit counterintuitive to what the knee's actual structure, like actual function is. Predominantly, the amount of work that I do with the knee is away from the knee. So I do a lot of work in terms of foot and ankle rehab and HPTs in the foot and ankle, or rehab through the hip. And I do a lot of work in the calf, or calf and hamstring, in order to actually gain the mobility we need from that knee joint in the first place. You will see a lot of different HPTs online with people like, doing thrust where they like jump down on the knee like that and all that kind of jazz. I think the safety implication of that and the risk benefit doesn't weigh up. But again, you can HPT the knee very successfully, so I wouldn't be too scared about doing it. I would just definitely ask yourself, what we were thinking about yesterday about why are we doing certain techniques, is definitely make sure you have a rationale behind why you are doing the technique in the first place, yeah? So personally for me, I tend to just avoid any kind of manipulation through here. But really good techniques for some people, yeah? So we're going to target our manipulation now onto the fibular head, which the fibular head is located for everyone on this side, just over here, yeah? And for everyone on this side, just over here, yeah? We can articulate it and move it around fairly easily, yeah? We can see that there's a nice amount of movement in both. So we're not struggling with our mobility now. So, the reason why the hamstring is quite important as well in terms of rehab for the knee and for the fibula. Obviously, hamstring attaches onto the fibula head, doesn't it? Yeah. So if we have a poor hamstring kind of coefficient in strength output, you're not going to get a lot of free centric loading. You're not going to get a lot of tension through the fibula. Which, if you're not getting a lot of tension through the fibula, then our foot mechanics don't work very well. Yeah. So we need this to work in order to make this work. If this doesn't work, then this doesn't work, which then shuts that down again. So you have that kind of big cycle of, like what's happening first, we don't necessarily know, but mobilising the fibular head could be something that you guys look at in terms of the treatment plan moving forward. Right, so what we're going to do is we're going to manipulate the fibular head with our first MCP contact, yeah? If I go just straight onto these fibular heads, like that's quite tender, yeah? That's tender, not very nice, yeah? You've got a lot of nerves coming around the back of it. We can make it a bit pins and needly, not very comfy for the patient, yeah? So what I'm going to do is take this contact, and I'm going to put it onto the medial head of the gastrocs, yeah? Once I get to the medial head of the gastrocs, I'm going to take a skin drag and pull all the way to the outside and behind the fibular head. So I've basically drawn all that tissue from behind the knee and put it right in front of where that fibular head should be. Now all I do is I pick up the leg, which is a big leg, so I'm going to put it down a bit, yeah. I pick up the leg, and you see how I'm using this control at the minute, is I then produce external tibial rotation, where the external tibial rotation is then going to put the fibula posterioralizing against my MCP contact, yeah? You can do it from this position, or you can do it from this position, whichever one you're more comfortable. Because his leg's a bit bigger, I think I feel a bit more comfy in here. If his leg was a bit smaller, I'd probably be on the tibia, yeah? So it depends on kind of where you feel more comfy. Because it's a bit more weighty, this is where I'm more comfy. So what we do then, is we then keep drawing that hand up and trying to push the tibia almost medially, whilst producing the external rotation from the lower, yeah? So that's binding that tissue up. You see how I'm dropping his leg out? This is the position we're in for when we then produce our thrust. Major thing to be very aware of here for guys and girls is if you over thrust the foot is going one way, yeah? Be very, very careful that we are not injuring our patients when we are going through with our techniques, yeah? So be very, very careful. I've had that done once to me and it wasn't very nice. So I tend to drop out quite a lot so that even on a high ankle, we're never really going to get anywhere. So it doesn't really matter how much you drop out, which is obviously if you're doing it in this plane, you see how much closer we go, yeah? So the hand that we're now thrusting with is this hand, not this hand, yeah? This hand is just building that tension up behind the fibula, and then all we do is we work with our breathing, and then we thrust with the external rotation vector in. Remember, with peripheral joints, the likelihood of us getting a manipulation and a big crack through it is very low, so don't be alarmed if you do not get the cavitation as such with it. Please do the retesting and see whether or not you're being effective, yeah? I'd say it's probably 50-50 if we get a manipulation through the fibula, yeah? So I wouldn't have thought we'd get, and if you get one, it's not a very big crack at all, yeah? Right, so all you do is once we're in this position, hands drawing itself out, rotation through the tibia externally, drop the knee out, get our focus point through there, deep breath in and out, build, 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 thrust. So we've got a little cavitation there. And that's it. So you see the thrust is from here, like that, yeah? And you see even with the thrust that I did, we were still pretty close, yeah? So be very, very careful of where you are putting your hands, yeah? You do not want to be getting sued because you kicked our patient in the nuts. Yeah?
Is your thumb in or is it on?
We made them do it. Yeah. The thumb is doing nothing.
Can you demonstrate?
It's outside of the. Okay, perfect.
Can you demonstrate on this side?
Yep. Heavy leg. So on this side, exactly the same. MCP contact. We draw under to then draw out. Yeah. So you see what tissue I've grabbed, and now we're sitting behind there so that we don't contact the back of the fibular head and it be sore. When we are doing that, guys that have very hairy legs, be prepared to get your hairs ripped. Yeah. Luckily we don't have that problem too much here. And then we pick the leg up, we externally rotate the tibia, we draw up the knee out, keep drawing the arm. So you see how I'm still using my hips to rotate everything out, and then the thrust is done in that position. Yeah? Nice and easy. Yeah? It seems like a complex movement pattern, but it is quite easy. I would say realistically, I'll probably do this technique like maybe once a month. I'm probably seeing around 300 patients a month-ish, yeah? So I don't use it a lot, but I still do use it. It's just, I think, for you guys, is working out your rationale as to why you would use it, yeah? What I'll do is, I'm going to show you now as well an articulation for the knee, which I think works really, really nicely. With articulation, we're working on basically just fluid secretion in the joint, which will generate movement through there. I would personally just work on knee articulation rather than HVT in it, personally. So I'll just show you that just so you can practice that as well, yeah? So here we go on this side. Really easy technique, but I like techniques that are easy and then have high payoff through there. All this is a short lever kind of movement. We just fix the femur, go onto the tibia, lean over, we just secure ourselves in, and then all I do is I drop my shoulders to the right, and then we just start producing some nice articulation short lever of the knee. But real nice, effective, safe, and it's just going to work on basically doing that to the knee joint, which is then just going to improve that friction coefficient in the joint, which then gets more secretions coming out, which then improves the mobility. We're not compromising any structure through that position. Make sense? So have a little play around with both of them and see how you feel. But yeah, that's what I kind of want you to work on, is just that fibular HVT, and then just try and work on that knee articulation as well, see if you like it. Yeah? Good? Cool. Prone means that you can't kick them in sensitive areas, so this might be a reason to doing it prone. Otherwise, just if you're in the position, really. It's just another position for you to work in. We're going to stand now facing away from the head of the patient, which is something we very rarely do. You're going to bring the patient's foot up. Once the patient's foot up, your inside hand is then going to be your stabilizing hand. We're going to do the same thing, but we're going to now take a contact onto the back of the hamstring. You're going to try and take that tissue drag from the inside back to the outside, so we're creating exactly the same. We're going to create that external rotation here. And you see how I'm going from here, move forward, and I'm in this position, and then it's just deep breath in, out, sink, 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 and you thrust. Yeah? So it's exactly the same technique, just in a different position. For the patient, you are doing exactly the same process, you're just doing it in reverse, yeah? It's upside down pretty much, yeah? So start on the inside of the gastroc head, pull to the outside, drop in. You see how I'm coming from backwards to forwards with my body? Because I don't want to get here and then have to push a lot. So I get here and it's just a nice, because I'm over the top of the joint again, yeah? So make sure you're using lots of body movement to get up and over and then bang, yeah? Really easy. If you got the first one, you'll get the second one, yeah?
Are you internal rotating the leg, the ankle?
No, I'm on the tibia. So unlike the first one where I can do it from the foot, I'm going to really struggle to do it from the foot here. I'm on the tibia and I'm externally rotating the tibia. The reason we externally rotate is to bring the fibula in contact with your MCP.
Okay.
Yeah? Make sense?
Yes.
Good? Everyone cool with that?
Yeah, one more time.
One more time. Just once?
Yeah.
Here? Yeah? Across. Step forward. Round. Externally rotate. And there. We can articulate it from this position. Or we can thrust it.
Okay.
Yeah?
So externally.
Right guys, so feet. If we are manipulating feet, yeah, I think feet are wicked to manipulate just in general, by the way. Is do make sure, what?
It's Chelsea Liverpool.
Just make sure that we have ruled out the possibility of any ligament or tendon injury through here and any kind of stress fracture. Because the force that you put into foot manipulations are a lot higher than the forces that you'll put into manipulations anywhere else around the body, yeah? You end up dragging the patient a little bit on the table a lot of the time, so just make sure you have ruled out any kind of red flag or an injury that you could make worse with a thrust technique, yeah? If someone does have a foot that is unstable or you're questioning stability through there, definitely don't thrust it. You could work with articulation instead, yeah? First one we're going to look at is the talus, yeah? Really, really nice adjustment, but again, it's a lot of force into the adjustment. It's all about hand placement and body position, yeah? We will see it, that loads of you just get the foot into this position and try and yank it as hard as you can. It is not how you do the technique. It's all about just how you lean onto the patient, yeah? So, talus is going to be located just through here, yeah? I'm going to take the inside hand finger contact on top of the talus, yeah? We're not going onto the tib-fib joint, we're going on top of the talus. So if you're struggling to find the talus, dorsiflex the foot, yeah, and then we can then, plantarflex the foot, then you can find the talus through here, and you put your middle finger on it, and then bring it back up into dorsiflexion, yeah? Everyone happy with that? Once you've got that middle finger contact, you see my thumb then goes to the base of the metatarsal, and you see how already I'm starting to create supination in the foot. The reason being is if I can create supination through the foot, is I start to lock out all the mechanics underneath the talus. Make sense? If I don't do that and I try and just manipulate it here, you see how, look, it's all floppy. Whereas if I do that, you see how his foot is pretty much fixed, yeah? So it gives me a stable base to then work from. The only reason you wouldn't do this technique is if you have a giant foot and you have a small hand, yeah? If you have a giant foot, small hand, which sometimes does happen, or just a giant foot, yeah, we will not be able to do the supination. So you will have to get good at just having a big firm grip around it, yeah? So there is times when we have to adapt, but 9 times out of 10 if we can, let's put the supination in. We then go through and reinforce around my middle finger contact. You can, some people do that. I prefer to interlace. I feel like it gives me a little bit more kind of stability through there. And then I pick up the ankle, yeah? And you see how I'm starting to dorsiflex the foot. This is where my chest stays. The whole technique now is as close to the foot as possible. You see how my body positioning is now straddling the bed, yeah? So I'm trying to be as close to the foot as possible. All I'm gonna do now is go from front foot pressure, all my weight on my front foot, is lock my arms out and go all my weight to my back foot. You see how I'm now locked into position, yeah? And then all I do is ask the patient to take a deep breath in. And on the out breath, I start to internally rotate the leg. The reason I internally rotate the leg is to try and lock it out. So you see I'm now at the hip joint. As I keep it loose, you see the knee joint's involved. Yeah? So, sorry, start again. So patient internally breathes in, and then out, internally, find that focus, and then it's just short, sharp, push back. Yeah? And that force is not me pulling in terms of doing this. All it's doing is me going from that front foot. You see how my back heel is in the air? All I'm doing is because I'm so locked out in that position, I just drop to my back foot.
Okay.
So I literally just drop because I'm so tight, drop like that. You see how the movement I produce from there, yeah? So keep nice and close to the foot, and just that at speed. So it's 1, 2, bottom. That's how you thrust it. When I was taught this at university, I was taught to just pick up the foot and try and throw it behind you, yeah? And it's a really poor way of teaching you to do it, because all they do is go, wang, just try and throw it behind you, and you end up just like yanking the patient off the bed, and you're just using brute force to try and, you know, gap the joint, whereas what we want to do is use this finesse in order to, you know, generate some speed in a drop-in motion. Make sense? Because this takes the technique from being a super complex technique where we have to generate huge amounts of force into just a simple drop. Make sense? Yeah? Take your time on this one, because you'll pick it up and it'll feel like shit and you won't be able to do it, but the more and more you practice it, the better and better you'll get, yeah? Peripherals are hard, so just take your time on this one. Again, we've got to think about reasons why we would be manipulating a navicular cuboid. We'd think about reasons why we are not gaining pronation and supination into the foot. So this is a really good technique if we're thinking if we've already exhausted our avenues with our hamstring or with our fibula and our talus, that's all not working. We can then start to work through this midfoot portion, yeah? In order to gain access to the navicular, the easiest way to palpate it is to find the medial malleoli. Go down and go just across and you'll find your navicular tubercle. It's a nice kind of pointy, archy bone on the inside of the foot. That's where we're going to be taking our contact to start with. Yeah? Everyone happy with that? Yeah? Cool. Right, so patient's legs both straight. Thank you. Right, so I'm going to be doing this side. Right, so as we said, first thing we're going to do is find the navicular tubercle. So I'm going to contact onto the metatarsal, slide down the metatarsal and find a lumpy bit at the end. That's my navicular tubercle, or I could go down and across and find the navicular tubercle. Once I've got it, I'm going to point to it, yeah? Once I've pointed to it, MCP contact on it. I'm then going to put my hand across, and then this is creating my thrusting angle, yeah? I'm then going to reinforce that position with my hand, yeah? Once I've done that, I'm going to drop the leg off. And then once I've dropped the leg off, I'm going to let it go a little bit floppy, yeah? Reason being, I'm going to keep my arms dead straight, and then what I'm going to do is I'm going to step over the leg, yeah? So you see how I've kept my arms straight? The reason this is because I need my arms to be behind me, so when I squeeze my legs together, I create a locking point, yeah? So once we get over the patient, I then use my adductors to really squeeze against my forearms to create a locking sensation. My knees are bent. My knees have to be bent so that what I'm going to do is straighten them, and that creates my thrust force, yeah? So once I'm in this position and I feel like I've got a nice tension, I then create some micro movement in order to find my locking sensation. Once I've found that, all I need to do is straighten my legs to make the thrust. Patient takes a deep breath in and out. We follow, 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 and we thrust. Yeah?
Yeah.
So you see how it's a lot of force, but all I'm doing is just straightening my legs. Yeah? If I try and straighten my legs and I don't have the squeeze on my arms, I completely miss it all. Yeah? So once we're in this position, straight arms, go over, try and get the foot out the back of your legs, squeeze the legs together, lock in, micro movement, and then bang.
This leg is not gonna straight. It's going down always.
Yes. Yeah, make sense?
Yeah.
You might get a head rush when you're doing this technique. So it's quite a lot of force through the technique. So again, if someone's got a compromised ankle, not a good technique for them. Yeah? So cuboid is obviously located at the end of the styloid process on the outside of the fifth metatarsal. Yeah? So easiest way to find it is sliding down the outside of the fifth met, find your styloid process, hook in just underneath, and here is where you're going to find your cuboid. Obviously, probably historically we would have been taught that cuboid drops, you know, like inferior, all this kind of stuff, yeah. Remember, we're just going to be gapping the joints, we're not actually going to be changing the position of the joints through there. So just as like kind of a full process, you might find that people come in and say, I've got a drop cuboid, can you please fix it for me? You might be a bit confused, yeah? So just make sure that we're kind of educating patients about that. I often have people come in who want a dropped cuboid fixed and stuff like that. So in terms of educating people, that's quite a big one. This technique is super, super simple, really, really easy. All we do is we take like a V contact to pretty much hold the foot, yeah? And that's kind of the biggest thing through the technique. Doesn't really matter how small your hands are and how big the foot is you take a V contact through there, and you've got a forearm to support the foot. So if we have like a super big foot, it might be coming up here, but as long as I hook my elbow into my hip joint, I've got full control of how the foot works, yeah? We are taking the foot into an external position through here to then thrust inferiorly, well superiorly with the bone, but inferiorly for us. You can see that we take quite a big stretch mechanism around the outside of the ankle joint. Obviously, if we're having a big stretch down here, it's not going to be good for anyone that's got any instability in the ankle or got any ligament issues, or someone who has been doing, you know, a lot of activity where the tendons are super overworked or anything like that. So do be aware that this position can be quite provocative again for people. So if you've got athletes that you're working with that are, you know, like ultra runners, stuff like that, if we're then going to be putting like boom, acute kind of thrust through there, it might not be the nicest thing for them. So again, I very much pick and choose when I do this technique, but I do use this technique more frequently than others, but it's just picking the right people that you're going to do it with. So once you take your V contact, yeah, so again, just literally around the talus, hook in your elbow onto your ilia, and then what you're going to do is take a pisiform contact. Remember our pisiform contact from all our spinal stuff? And we're going to do it on the base of the cuboid, yeah? So again, find our styloid process, and then here's our contact there, yeah? What we're going to then do is we can't thrust in this position, yeah? We're then going to make sure that our arm and our thrust force from our elbow down is where we're then looking to get the manipulation to go through, yeah? I think that just went, didn't it?
Something went but
Yeah, I think that just cracked on this side. Well, we'll try it anyway. So we'll be in this position where where the elbow is elevated, so that when we thrust, we're thrusting inferiorly with our arm. If we're doing it like this, you see how we've got no force to generate, yeah? This is going to be our fixed point, and we do not drop the arm, we're just twisting the hips. So the hips twist externally, your arm doesn't do that. Make sense? Yeah. So a lot of people get this wrong, because if we drop our arm, we can't thrust against anything, can we? So what we need to do is make sure we're nice and fixed in, solid on here, round, above the joint, like this. Patient takes a deep breath in, and on the out breath, we bind, and and we thrust. Yeah? So nice, super easy, bang, through there. Yeah? We see how the thrust as well is not me trying to smash his foot to the floor. It's my hand staying solid and then me creating a little drop in my body, which then creates that kind of micro movement that's going to create the thrust. Make sense?
Yes.
Yeah? Do you want me to show you that again, or are we happy with
Can
it?
you repeat on this one?
Yep. So, start off with our lead contact position. So again, between index finger and middle finger, nice and secure onto the forearm or onto the wrist. We want this movement to be nice and kind of rhythmical, so that when we're moving outwards, we can then just thrust. Fifth metatarsal styloid process, drop in through there, and then we're going to take a pisiform contact on that. We're then just going to get our body position right, where we're learning to get the elbow high up above the joint, keeping this nice and solid. So then patient just takes a deep breath in, and on the out breath, follow, 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 and we thrust. Yeah? So again, you guys are finding this is probably quite the key thing at the minute. With peripheral joints, they either crack loads or they don't crack at all. So again, do not be alarmed if you're not getting cavitation from these thrusts that you are doing on the peripheries. It very much happens or doesn't happen. The thing you have to do is recheck your work to see whether or not your thrust has been effective, yeah? Like that one went, that one didn't go, but they're both exactly the same thrust. So I would not be alarmed if you're not getting cavitation on every one you're doing. Make sure you are going through the process of checking whether or not you've been effective or not, yeah? Because I think some people can get really hooked up on that, especially with the tailless one, will be yanking people's legs forever and ever and ever when you've already mobilized it, yeah? So do make sure you are checking after every adjustment that you are doing, whether or not it be a passive assessment or even a functional assessment, because you may find that the passive restriction isn't budging at all, but functionally you've got that joint working really well. So make sure that we are retesting after you've done each technique. I'd say the maximum I'd ever try a thrust for a cavitation is twice. Yeah. So I try it once and go, oh, did I fuck that up? And then I try it again. If it's not gone, then I'm retesting it. Yeah. And then we're then seeing whether or not we're effective. Make sure? Make sense? Sorry. Yeah. Good. Perfect. Right, so guys, technically this is the last technique we will be showing you officially. I am going to be hanging around if you want to see any other weird and wonderful techniques afterwards. So do not be alarmed if I have not shown you something that you want to be shown. That's not on the curriculum. Yeah. Right, so here we're looking at a talocalcaneal joint. So a subtalar joint through here. Subtalar is a really interesting joint. It allows the pronation supination mechanism to come through the foot. So in terms of if your foot mechanics are not working correctly, this joint is what I look at heavily. I like to articulate this joint rather than thrust it, but that's my personal preference. Again, there's loads of other stuff that you can do to this joint rather than thrusting it. But what we're going to do is we're going to basically add pronation and supination to the foot. By doing that, you end up by locking out this joint, and then we're going to put a thrust through it. I'm going to show you two different ways you can do this. Two different ways, yeah? So two different ways that we can do this technique. And then I'll show you the articulation as well, so you can have a little play around with both of them and see how you feel with it, yeah? The two different techniques are just hand placement differences. Body weight's going to be in exactly the same position. Thrusting is exactly the same, it's just hand position, yeah? Cool. Our feet are probably toasted, so I doubt we're going to get many manipulations or cracks out at the minute. But subtalar joint is just through this position. It allows pronation and supination to come through. So patient is side lying. You see how normally patients, when they lie side lying like that, very unhelpful when you want to manipulate their subtalar joint. I just ask the patient to bring this knee up and out the way. Yeah. Normally, when you ask a patient to bring their one knee up, what do? They take both knees up. Yeah. So I make sure when I ask that, I keep a hold of this one. Yeah, just so they know. So just a little trick of the trade for you guys. Yeah. Push this one slightly up, because what we don't want to do is be manipulating their foot on the end of the bed. I then just manhandle their foot up slightly. I'm going to take a hand hold round like this onto the calcaneus, and then this, a kind of a paddy part of the hand onto the metatarsals through here. By just putting my body weight through here and manipulating my body over the joint, you see how I'm now adding pronation to the calcaneus? Yeah? So that is my is my pronation element. Yeah? I then, once I've fixed that in, take hold of the metatarsals, and then I lean forward, adding my supination element. Yeah? So I'm now pushing into pronation and into supination. Make sense?
Yeah.
This is an articulation here. I then build to the barrier point like that. I then ask the patient to take a deep breath in and out, and I follow, and then I thrust. That's crap. Yeah?
And then you say, oh.
No, then I go ka-ching. Yeah? So then that's number one. Yeah? So that's a first hand position for a subtalar manipulation. Yeah? Everyone happy with that?
Yeah.
Is the thrust straight down?
Straight down.
Right.
Because we put in the vectors so that we just go gap. Yeah?
Chinese bird, effectively.
Pretty much, yeah.
So your, sorry to interrupt, but your thumb is going across the medial malleoli.
My thumb, yeah, it's just,
The right hand thumb.
they could be tucked under me. My thumbs are doing nothing.
Okay.
Remember, it's how I put my hand placement on in the first place is then, so because I'm leaning over, it's driving me backwards, and because I'm leaning over, this is driving me forwards.
Okay.
Make sense?
Yeah.
So this is everything, and then it's just into it.
Okay.
Yeah? But you see the thrust was really nice and gentle as well. You'll see people try and do this technique and they put everything into it. Trust me, the foot will either go or it won't go. There's no point trying to jump on it. Yeah? Let's pop you into the other side so you can get the other one to go. So, there we go. Well done. So now we just take exactly the same mechanism, but instead of the hands being in this position, we cross them over. Yeah, so again, it just guides you a little bit more. So by having the hand here, and then me leaning over, it's pushing me into pronation again. And then having the hand here, it leads me into supination again. I would say the first one, you probably have a bit more of a bias towards the pronation, and this one, you probably have a bit more of a bias towards the supination, I would say. Yeah. And all you're going to do, again, you see how my arms are completely straight? All I do is go from back foot pressure to front foot pressure and then drop. That's my thrust force, yeah? So all I'm going to do is ask the patient to take a deep breath in and then out, follow, thrust. Yeah? Exactly the same technique, different side, didn't get the adjustment through in terms of cavitation, but then I'm sure if I assess his foot, his subtalar is moving. Yeah. So again, don't be alarmed, especially with feet, because they are just freaking nightmares to work with. If they're not cracking, it's not the end of the world. Just keep on retesting. I think that's the biggest thing in terms of for you guys early doors with peripheral manipulations. Is if you don't hear the crack, your confidence can go out the window pretty early because you're thinking, oh, I'm not being effective. But trust me, the cracks don't come every time at all. It just really doesn't matter about the sense, like the cavitation. Just keep on retesting to make sure you're being effective. I'll just show you the articulation as well that I like to do. So obviously the articulation on both of them, the hand holds before is an articulation. So the setup of the technique itself. If you pop onto your back, the way that I really like to articulate the subtalar joint is pretty much we then take contact on the calcaneus. Then we take a contact onto the base of the metatarsal through here, so we create pronation, supination. I lock into my chest, and then I just start to articulate like that. And I feel like this is a real low energy cost, but then a really effective technique. Like this feels really nice in the foot, don't it? Yeah, you get a nice big kind of articulation through there. Yeah. So give all three a go to see how you feel. Remember the line up to the first two thrusts is an articulation as well. That's just as good. Practice the articulation first, get to your barrier point, try and smash it. If you can't, don't worry, retest it, and then we'll see how it gets on. Yeah? Good. a little bit of extra on the shoulder. These techniques, again, like every peripheral, will either cause a cavitation or it won't cause a cavitation. Please be checking afterwards if you have got anything to go through there. We are going to be thrusting onto the GH joint here. If the patient's joint is compromised in any way, do not do this technique. Yeah? If it's got any structural deformities in it, anything like that, it is not a good technique to be doing on them. So be very, very careful. Please do not do this with anyone with a shoulder injury. So,
Whom would you do this on then?
pardon?
Whom would you do this on then?
For someone that we needed to gain more range for the GH specifically, so for instance, if we've got a patient with neck pain and we're doing a lot of
On time.
yeah,
Yeah,
and we're doing a lot of our rehab work and treatment through the thoracic spine shoulder, I normally would do this sort of technique if I wanted the GH to gap and create more kind of movement in it as such, if I want to get more overhead reach or something like that. So again, every technique is dependent on the patient, and it's just having more in your arsenal that if you're like, oh fuck, I really want to get that GH to go today, this is something that we can put into it. Make sense? Right, so, but yeah, neck pain. Again, shoulder pain is fine to do it on, but we need to make sure that the patient's not compromised. It's the biggest thing, yeah? So, you see how I'm really close to the patient? This is where having a really big belly pays off for me, yeah? So I can push into the patient and I'm in control of the patient and it's really nice and comfy. I then wrap around the patient like this and I take control of the elbow. I create a locking sensation here through my fingers, yeah? I'm then gonna just wind, and you see how my leg's on the bed, stabilizing so that I'm nice and in control of the patient. We then create a little bit of backwards translation towards me, just to find a bind, and then I go around, move the patient, so I find up a locking sensation in the joint. Normally you'll find in a little bit of adduction in the patient, and a little bit of flexion, we'll find a locking position. Patient then will then take a breath in and out, but when he does that, I'm going to be leaning back, yeah? So all we're going to do is take a deep breath in, out, and on the out breath I lean back, follow, 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 and thrust. Just a nice, short, sharp, boom, back. And we had a tiny little cavitation through the posterior capsule. So again, patients that you might want to do this on is if we have neurological instability in the shoulder where posterior capsule is really tight, anterior capsule is really sort of like lack, we can get stimulation through the back and then start our neuro rehab on the front. So you know, like again, it's just nice little techniques that you can put in there for certain things. So we move your shoulder now, we're like, oh yeah, massive, yeah, roof was really good. Yeah, patients are, oh yeah, let me give you as much money as possible. Yeah, so you know, that is just a nice technique to have in there because we've not really done one on the GH today. I think that's just a nice one to add in. Yeah, so give that one a whirl.
Can you just do the other side, please?
Yep.
Thank you.
No.
If you turn it the other way.
Or you could just.
Very quick.
Yeah.
That was easier.
Yeah. All right. Patient hand goes behind the head. I come round, take a contact onto the elbow and interlace my fingers. The likelihood is you're going to find that the bind up point comes in some adduction and some flexion, yeah? But again, work with that kind of joint to find where you feel that barrier point come through. Once you find that barrier point, so I find that barrier point in a bit more adduction this time, I'm going to take a little bit of a lean back. Patient takes a deep breath in, and then on the out breath, we follow, follow, follow. And again, small, sharp movement, and then just a nice little cavitation comes through the back of that capsule. Again, guys, do not be trying to pull someone's arms off. This is a very gentle technique, yeah? It might look like I'm putting a lot of force into it. I'm really not. If you push it too hard, you could damage the shoulder. So really do not push hard with this one. It's a small, fast, like that, and that's literally all I'm moving. So do not try and manipulate the shoulder like you're manipulating the talus, yeah? We are doing very short movement on this one, yeah? Give that a whirl, and that's the last one we're gonna go through today, yeah? Cool?